Thank you for joining me in this year's ACP Arizona Chapter Virtual Conference 2020. My name is Stephanie Miljkovic, and I'm a third-year medical student at Creighton University School of Medicine, Phoenix Regional Campus. And today I'll be presenting a case, an interesting case of an atypical carcinoid neuroendocrine tumor of the lung, and how we were able to manage it with bronchoscopy. To give a little bit of background on our patient, she was a 58-year-old female with past medical history of tobacco smoking, inhaled methamphetamine use, chronic anemia. She had a morbid obesity, she was homeless, and a pertinent family history included lung cancer in the father. And at this point, I'd like to mention, because we later find out she has an atypical carcinoid tumor, there really isn't an association with smoking at this point, but still at that point, we don't know yet what it is. On review of systems, she endorsed sweats, she had shortness of breath, productive cough. She did have bilateral knee and shoulder pain, but not quite as related to her current state. On physical exam, she was morbidly obese, no lymphadenopathy on palpation, and on lung exam, she had decreased lung sounds bilaterally with wheezes and coarse breath sounds over the right lung base. Her vitals, she was tachypnic with hypertension, and her labs did show this evidence of a chronic anemia, which was likely unrelated to her current state, as we had reviewed her records prior, and she had, this was her baseline, around 7.4, upwards of 8.1, 8.2. But what really struck us is when we obtained the CT scan, and I'll delineate here with a highlighter, is this finger-like projection, lobulated opacity that projects into the segmented base of the right lower lobe here. And this is quite characteristic of what's known as a bronchocele, otherwise known as a mucocele, or again as mucus plugs. And this was what we thought we were getting ourselves into. So we ended up doing a bronchoscopy, and with my pointer, I'll go ahead and delineate some anatomy here. So this is our main carina, separates the left main and right main stem, and already we're able to see this whitish endobronchial lesion down here. And as we go further down the right lower lobe, we can see this quite well now. This is our right upper lobe, our right lower lobe, and so we knew here we had to start. It seemed pretty clear she had this mucosal plugs that was likely causing some sort of post-obstructive infection. As we started to forcefully clean it out with saline, with an alveolar lavage, we actually start seeing this unexpected tumor here. It's sort of multilobulated into the, I can give a little bit more anatomy. We have the base of the tumor, the main part of the tumor, just distal to the opening of the medial segmental branch of the right lower lobe. This is our superior, and actually we're completely occluding. This might be, no, I think we're still completely occluding the lower segments there. And then once we, so what we did here in order to remove the tumor, we used an electrocautery snare, and what that does is just a piece of metal loop that goes all the way around, and it not only excises but also cauterizes in order to remove the tumor, but also to prevent any further bleeding as a complication of the procedure. And so that we did just that, and now look at this. So we started cleaning up all of that mucus, and we can finally delineate the lower lobe. So as I'd mentioned, the tumor base here with the medial, just distal to the medial opening, superior, anterior, lateral, and just behind here, the posterior. So we can finally see that now. So you can imagine the improved symptoms that she experienced after clearing all that out. But our job was not done yet. We had to remove this tumor base, and we ended up using a diode laser to excise the rest of the tumor. And this is crucial in order to prevent tumor reoccurrence. We ended up taking that straight to pathology, which is a great benefit of having a pathologist right next door. The H&E stain showed no crushing artifact, so we got a good sample here. And as we stained it with synaptophysin, very strong positivity, helping us showing a favorability towards a neuroendocrine differentiation of this tumor. As we get closer with an H&E stain, you can start to see where the arrows are pointing to these mitotic figures here, very classic of a carcinoid tumor. What's not terribly consistent with an atypical carcinoid tumor was this patchy necrosis, as you can see here. But, it's not to say that if she's had this tumor for a long time, she starts to get necrotic tissue within the tumor itself. It could happen, but it's not necessarily one of the characteristic features. As we move on to clinical management, this is sort of the importance of the case, right? So we were able to excise her tumor with the electrocautery snare, as well as pulling it out with the cryoprobe so it is removed out of the airway. We did perform a fine needle aspirate of all the local lymph nodes, and we did find positive metastases in the subcranial and right lower paratracheal lymph nodes. This was a form of primary management. We did not surgically resect prior. We really didn't know that it was there. It was really quite masqueraded by this bronchoceal on top, but the atypical carcinoid tumor was in fact removed with bronchoscopy using the diode laser for the base removal. And as outcome and her follow-up, the next day, post-operatively when I visited her, her cough and dyspnea were immediately improved. She did have just some cough and pain just from the procedure itself, but really we were able to de-escalate her from a non-rebreather mask to a nasal cannula to eventually discharging without O2. And then we referred to oncology, where she does now receive cisplatin and paclitaxel with radiation, and her tumor is currently staged at 3A. So, by using the bronchoscopy and the diode laser as primary management, there were several benefits to this. For one, we were able to remove the tumor to prevent it from growing and to minimize bleeding. We were able to facilitate immediate pathological diagnosis right in the procedure room, and stage it properly using the fine needle aspiration, all within this procedure. Third, we were able to reduce the risk of any post-obstructive pneumonia. If you can remember, all of the mucus that we were able to collect out, both on CT, it was quite impressive, but also right when we were in the flexible bronchoscope, we could see really how much we took out. And lastly, we were able to, by using the diode laser at the end, with the base excision of the tumor, we're able to reduce that residual tumor burden in order to prevent recurrence. As very brief background of the atypical carcinoid tumor, of all primary lung tumors, carcinoid tumors comprise only 2%. Of that 2%, only 10% are considered atypical, not the typical counterpart. And so when we encounter this, it's quite rare. The other neuroendocrine tumors you would find would be large cell, small cell, and its counterpart, typical carcinoid. AC tumors were once thought to present early on with good margins, and we were able to treat it immediately with surgical resection for a definitive cure. But what we're finding is that actually within the literature now, 20% of these tumors, the ones that we've encountered in this exact patient, metastasize at the time of diagnosis and are consistently associated with worse outcomes and morbidity and mortality compared to its typical carcinoid counterpart. Which is why I think this case is important, because what happens for those 20% of people who don't qualify for surgical resection due to either metastases, as was the case with this patient, or any other reason for poor surgical candidacy? Traditionally, bronchoscopy served as a bridge. So someone coming with cough and dyspnea, pretty severe, quality of life is poor, but they're metastatic, they can't do surgical resection. You can provide bronchoscopy as an option to clear, let's say, the pneumonia, or I'm sorry, not the pneumonia, the mucus, any part of the tumor that can be. But in this case, and I'll continue here. So the effectiveness alone, though, bronchoscopy as the primary management for metastatic atypical carcinoid tumors is not very well reported at this point. In the past, it's well established that after surgery, you could use bronchoscopy to still resect the tumor base. So as I had said multiple times with the diode laser at the end to prevent recurrence, that was already well established. That was the mainstay post-surgical excision of the main tumor. And so to think that exclusive bronchoscopic intervention really has not been considered as the primary management. And so what we would like to propose here is a case in which, one, we had an atypical carcinoid tumor, which is somewhat of a rare pulmonary tumor. We also had it masqueraded by a bronchoceal or a mucocele, which changed our course of treatment in the way that we were actually removing a tumor where we thought we were only removing mucus plugs. And third, showing and demonstrating that for the patient's benefit, we were able to use bronchoscopy as the primary management with electrocautery snare and diode laser to primarily and definitively not cure, but most certainly treat this patient's condition, this metastatic disease, in order to improve patient outcomes. I hope this has provided you a brief and interesting case of a patient with atypical carcinoid tumor, and I would like to provide my references here if you would like further reading, and I thank you for your time in advance. Have a great rest of your time at the virtual conference. Thank you.